Unilateral shoulder pain is a very common complaint in the primary care setting, and many students have difficulty evaluating and diagnosing shoulder pathology. This is due both to the complex anatomy of the shoulder as well as the many clinical maneuvers for investigating it. This video seeks to simplify the process, demonstrating a basic exam focusing on the most important provocative maneuvers, allowing for a quick and accurate clinical diagnosis. The shoulder has a large degree of freedom of movement. Stability is provided by the glenoid labrum, a ring of cartilage surrounding the humeral head, as well as the rotator cuff, a group of 4 muscles surrounding the joint. Supraspinatus, infraspinatus, teres minor, and subscapularis. Additionally, the tendons of the biceps brachii are intimate with the joint and can cause pain when irritated. It is important to establish both the active and passive range of motion of the patient, as this can help to identify different pathologies. For example, the passive range of motion can be significantly reduced in frozen shoulder or adhesive capsulitis. The normal ranges of motion should be approximately 180 degrees of abduction, 45 degrees of adduction, 135 degrees of flexion, 45 degrees of extension, 70 degrees of internal rotation, and 45 degrees of external rotation. The most important step in evaluating shoulder pain is obtaining as thorough a history as possible, including any inciting injury, as well as the timing and severity of the pain. Additionally, it's important to remember that shoulder pain can be referred from other organs, such as the heart, the spleen, or the gallbladder. And finally, cervical radiculopathy can also cause shoulder pain, so a thorough neck exam and relevant neurological exam should also be considered. As with any joint exam, one should inspect, looking for asymmetry, atrophy, or obvious injury, palpate, evaluate pulses, sensation, and reflexes. Rotator cuff injuries are very common, especially in people over 30. The most common injury involves supraspinatus tendinopathy, caused by repetitive motions usually done at or above the shoulder level. The empty can test is the most common test to evaluate for supraspinatus injuries. To do this test, have the patient place a straight arm in 90 degrees of abduction and 30 degrees of forward flexion. Then have them internally rotate the shoulder so that the thumb is pointing down. Push down, having them resist. Pain without weakness is consistent with tendinopathy, while pain with weakness is consistent with complete or partial tear. To further evaluate the rotator cuff, you can have them do resisted internal and external rotation of the shoulder. Another common ailment of the shoulder is impingement syndrome, in which tendons of the rotator cuff that course through the subacromial space can become irritated or inflamed, causing pain or possible weakness. The 2 most common tests to test for this are the Neer and Hawkins tests. Positive tests are not specific to any specific structure in the rotator cuff, although the supraspinatus tendon is the most commonly affected. The Neer, or passive painful arc test, is performed by stabilizing the shoulder to prevent any shrugging, and then passively flexing the shoulder forward. Any pain at 90 degrees is indicative of mild impingement, at 60 to 75 degrees moderate, and then at 45 degrees or less is severe. Another test for impingement is the Hawkins test. With the patient relaxed, flex their shoulder to 90 degrees with their elbow also flexed to 90 degrees. Stabilizing the arm, push down on the wrist, causing internal rotation of the shoulder. Pain with this is indicative of rotator cuff impingement. Biceps tendinopathy is a fairly common complaint, as a biceps tendon passes both through and around the shoulder joint and can often become irritated and inflamed, causing shoulder pain. The most sensitive test to test for biceps tendinopathy is the Speeds test. To perform this test, have the patient fully extend their elbow, flex their arm to about 30 degrees. Then, stabilizing the shoulder, apply downward pressure. Pain in the anterior shoulder indicates a positive test. A less sensitive, though more specific test for biceps tendinopathy is Jurgensen's test. Have the patient relax their arm at their side with their elbow flexed to 90 degrees and their forearm pronated. Shake the patient's hand and stabilize their shoulder, and have the patient attempt to supinate against isometric resistance. If pain is elicited in the anterior shoulder, this is a positive test. In order to test shoulder stability, we'll be demonstrating the apprehension, relocation, and release tests. These tests are best performed with the patient in the supine position. For the apprehension test, have the patient place their arm in a throwing position. Then apply firm, steady pressure on the posterior shoulder. Apply downward pressure on the wrist, causing external rotation. If there is pain or a feeling of impending dislocation, this is a positive test. The relocation test is essentially the opposite, with the forces being reversed. Apply firm pressure on the anterior shoulder, and if there's any lessening of pain or if the feeling of impending dislocation goes away, this is a positive test. The release test involves just a rapid release of pressure off of the humerus at the end of the relocation test. If again there is pain or a feeling of impending dislocation, this is a positive test. In the primary care setting, in the absence of a significant tear, conservative measures such as rest, ice, and physical therapy are tried for a period of about 3 months. If symptoms continue or worsen, then an orthopedic referral is warranted. I hope you found this video helpful in approaching the clinical shoulder exam.